Hello, welcome to Research Medical Center Transplant Institute Pre-Education class. My name is Mary Lee Kleitz, and I'm the Director of Transplant at Research Medical Center Transplant Institute. We are so happy that you're giving us the opportunity to help you through and assist you with your transplant journey. Before we get started, I'd just like to remind you about a couple of things. The first one is that your designated caregiver also needs to participate in this education, as it's a requirement for our evaluation. Secondly, if you have any questions, be sure to write them down as we move through the slides so that we can get those questions addressed when you come in for your appointment to visit the team. Thank you again, and welcome to the Research Medical Center Transplant Institute family.
Good morning. My name is Susan. I am the Waitlist coordinator here at the Transplant Institute, and this is the pre-education slideshow for kidney and pancreas transplant. Above all else, we are committed to the care and improvement of human life. What is a kidney transplant? The kidney transplant is a surgical removal of a kidney from either a deceased donor or a living donor, and it's surgically grafted into our recipient who has end-stage renal disease. Some of the benefits: no more dialysis. You're probably going to have a longer lifespan. You don't have to worry about your fluid intake or taking binders with your meals. And also, you're going to have a lot more flexibility in your lifestyle. Some of the risks: possible depression after surgery, recurrent kidney disease, possible side effects from the medications that you will be taking to keep your body from rejecting the kidney. As you can see here in this graph, as a general rule, what you're looking at here is in the gold are people and their lifespan, expected lifespan, while they're on dialysis. But in the blue, people who have been transplanted. Now, as a general rule, this is just regarding end-stage renal disease. It does not factor in all the other comorbidities that patients may have. This is just a general guideline. We have a whole team of people who work with you to get you listed. There's transplant coordinators who are all RNs. The pre-coordinators work with you to get you on the list. As a waitlist coordinator, I work with people who are currently listed until they get their transplant. We have a living donor coordinator who works with all of our living donors. Our post coordinators work with you after your transplant. And of course, our transplant surgeon, our transplant nephrologist, and then your referring nephrologist, who is your kidney doctor. We have pharmacy people, dietitians, social workers, a financial coordinator, our office administration staff, our living donor advocate, and our transplant director. All transplant programs across the nation are measured for their quality. We report outcomes for 3 years after transplant on both the patient survival and the graft survival. Graft is the actual kidney. We are above the national average on both. Now in this screen, this shows you all the different players who help put these transplants together. OPTN is the Organ Procurement Transplantation Network. They write the rules and regulations for all transplants in the United States. UNOS, which is United Network of Organ Sharing, they enforce all the rules and regulations, and we report to UNOS all of our outcomes. As a transplant institute, we work with all the recipients and the living donors, and we upload all of that information to UNOS's database. There are also OPOs, organ procurement organizations. Our local one is Midwest Transplant Network. Their team of people are out there in the ICUs working with all of the families of their loved ones who are deceased. They work with the deceased donors and their families and gather all the information about their health history, blood type, tissue typing, and they upload all of that information to the UNOS database. The UNOS's database gets that information and spits out a list of names of people who are possible matches for that particular donor. As you can see from this screen, this is going to show you the nation of UNOS and all transplants. There are 11 regions in the United States. We are region 8, and we're right in the Midwest. The way that the allocation is done now, what is considered local offers, whatever donor hospital the donor is in, all offers go out into a 250 nautical mile radius. So currently, being in Kansas City, we get a lot of donor offers out of the states of Nebraska, Iowa, St. Louis, Arkansas, Oklahoma, and of course, Kansas and Missouri. There are things you should consider when thinking about getting a kidney transplant. It's not a cure. It's a treatment, and it requires a lot of compliance. It will not cure all your other disease processes. You will have to take lifelong anti-rejection medications and other medications as ordered. You're going to have to go to lab and have your labs drawn at least twice a week for 3 months so that we can monitor the kidney function. If something starts to go wrong with it, we need to know that right up front so that we can fix it. The other thing that they're going to monitor when you go in for your lab draws is the medication level in your system so that it's not too much and it's not too little. It does require a lot of compliance. You will need to call us back when we reach out to you, and you've got to keep your insurance. Please do not think about changing your insurance until you talk with our financial coordinator, as there can be issues. Sometimes people will try to sell you on a different insurance policy saying that they cover transplant, but the reality of it is their sales reps probably do not know who we are contracted with here at Research Medical Center. It takes a strong commitment from you. Not everyone is eligible to get a transplant. Our first and foremost job is to make sure that you are safe to go through the transplant, you're safe to go through the surgery, and that you are healthy enough to maintain it afterwards. Some of the issues that we see, some of the things that we have to take caution when thinking about listing you might be if you have a cancer history, or you might need to lose weight. If you have a history of hepatitis B or hepatitis C, substance abuse, financial issues. Maybe somebody has a lower urinary tract that isn't working properly, or an active infection, or history of noncompliance. These are all issues that we are going to take a strong look at before listing you. Then again, on the other hand, there are some things that are going to be absolute reasons why you would not be eligible for a transplant. If you have a major infection going on right now, you're not eligible for a transplant. If you have a cancer that does not have a good outcome, such as pancreatic cancer or lymphoma, you are not eligible to be listed. If you have severe vascular disease, the surgeon's going to have to take a look at it to decide whether he or she can work with your vasculature system. And with that, I'm going to let you talk with our living donor coordinator.
Hi, my name is Katie, and I'm the Living Donor Coordinator here at the Transplant Institute. And I'd like to start by just saying thank you for gifting yourself with this time to educate yourself on living donation. We're going to talk today about what it means to have a living donor and how it can change your length of stay on the wait list. I want you to pull out the green packet in your folder so that we can refer to it as we go through the living donor slides. We want to end your wait on the wait list. Living donation is a gift that could come from a family member, a friend, an anonymous person, or we could do what's called a kidney paired exchange. And to talk a little bit about kidney paired exchange, we have a living donor, a recipient, A, and we have a living donor B and a recipient B. Living donor A doesn't match recipient A. Living donor B doesn't match recipient B. So we do what's called a paired exchange. Living donor B matches A, and living donor A matches the recipient B, and we can do a paired exchange. Living donation is an opportunity to help someone when you feel helpless. It's an opportunity to improve the quality of life of a loved one or someone else. There's no cost to the living donor for their evaluation or their surgery. We do what's called a laparoscopic procedure with the living donor. There's less pain, there's a shorter recovery time for the living donor, and it's less risk. We always want our recipient in their best health at the time of surgery. If a living donor would ever develop any type of end-stage renal disease after the transplant, they can be listed and worked up just like any other recipient, but they come to the top of the list. They will always have priority. What are the benefits of living donation? Living donation is your preferred treatment for end-stage renal disease. You're always going to get the best quality kidney. It reduces your wait time from years to months. A live kidney donor, in many cases, can last longer than a deceased donor. There's significantly better outcomes for recipients with live donors, and typically we see those kidneys start working immediately. We don't see that delayed graft function with a living donor. The longer you as a recipient are on dialysis, the more your health can deteriorate. And in some cases, you may no longer qualify for a transplant. By having a living donor, we can help prevent that. We will always schedule the surgery at the convenience of the donor, and we always, again, want our recipients in their best health at the time of surgery. This slide demonstrates the results of the survival rates for our patients and the donor kidney survival rates. In the orange column, you can see that patients on dialysis survival rate is much lower than those with a deceased donor or a living donor. And across the board, the living donor has the best outcome. Ending your wait for living donation. How do I ask? Well, first of all, you have to be willing to let someone help you. Start by discussing with your family and your friends why your doctor wants you to have a transplant. Explain that a living donation is your best option. Rather than ask, sometimes it's about telling your story. Tell your story, speak from the heart. Discuss how you can envision your life changing and improving with living donation. Educate yourself and others. Share the information from the slides and from the packet. So again, I want to remind you, your life may depend on your willingness to educate yourself and others about living donation. Give them our contact information. Our phone number here at the Transplant Institute is 816-822-8257. If someone has questions, all they have to do is call and ask to speak to the living donor coordinator. They can also go to our website, which the address is available on the green sheet in your packet. Now I'm going to turn it back over to Susan, our waitlist coordinator, who will wrap it up.
So what's your next step in transplant? We're going to have to evaluate you to see if you're healthy enough to go through the process. You're going to have all of your preventative health screening things done for us. These are things that you're going to do in your normal primary care doctor's office, such as colonoscopies, mammograms, pap smears, dental exam. If you are currently on dialysis, you're going to have your hepatitis B vaccinations, your TB skin tests, and then, of course, we'll get a history and physical from your doctor and a medication list. If we can move forward after all of that information is deciphered through, then we will move forward with the transplant evaluation testing. We're going to put you through cardiac testing. You will have a stress test. We've got to make sure that your heart is strong enough to go through this transplant. We'll do an EKG, a possible echocardiogram. You're going to have a chest x-ray. And then we will be doing a CT scan of your abdomen and pelvis just to check out your vasculature system. So you might ask, after all that testing, when am I going to be on the list? Well, we have to analyze all the tests, and then we take all of your information to our selection committee. Selection committee meets twice a month, and there are 3 possible outcomes. Everyone on our team is in that committee. We all sit down and discuss your case as a whole. The 3 possible outcomes are going to be, you'll be accepted and listed. You might be deferred. And what deferred means is, well, we might be able to list you, but you're going to have to take care of this first, or you're going to have to take care of that first, or we will decline you. And based on that information, you'll be notified that day and instructed how to proceed. But if you are accepted and listed, there usually is a 7 to 10 day lag time, because you're going to have other things that you have to go through to make it official. So it's typically a 7 to 10 day lag time before you're actually listed. Once you're listed, you will start earning points. Now, if you're currently on dialysis, those points started earning the day you started dialysis. If you are not, it is the date that we list you. And every day that you're on the list, you earn points. Sometimes those points are at a different rate, depending on what your status is, if you're on dialysis, if you're not on dialysis. But sometimes this is a deal breaker, in that if you and I are similar matches for this particular donor, and you have more points and more wait time than I do, you come above me on that offer. Caregiver, we have to have a qualified caregiver for you. We don't care if this person lives in your home. They don't have to be a family member. They can be a friend, a significant other. They can be an acquaintance. But this has to be someone that's reliable, someone you can count on, someone who has a telephone and has reliable transportation. They'll return your phone calls, and they can be available to you for 3 months, 24/7. We will expect them to sign a caregiver agreement, and they need to understand what is expected from them. It doesn't necessarily have to be one person. Sometimes we have people listed that have 2 or 3 different caregivers, and everybody pitches in to help. Everyone has the right to be listed at more than one transplant center if their insurance company allows them to. There are things that you need to consider first. It does not benefit you to be listed at more than one center here locally, because we are all getting the same donor offers. So we do have people who are listed in other regions, say Nebraska, Oklahoma, St. Louis. And what you need to remember about that is you will have to travel to that second location to get all of your work up there. Just because you might be listed at our center does not automatically mean that they would list you at theirs. And not all insurance companies will actually allow you to do that, so you do need to check with your insurance company first. If you do get listed at more than one center, it might increase your chance of offers, because you're going to be working with a different donor pool at a different transplant center. There are 2 different types of deceased donors. There's the brain dead donor. There are tests that are performed to analyze whether all brain activity has ceased. Brain dead donor is going to remain on the ventilator so that the organs are being perfused with blood and oxygen to keep them viable. And the best option is to have all of the organs placed where we know where they're going prior to that donor ever going to surgery. There is a donation after circulatory death. That is what we call a DCD donor. And that donor has minimal brain activity. So they may or they may not pass away once that ventilator is removed. If they don't pass away within the time frame allotted, which is typically 2 hours, then those organs are deemed not viable and we would not use them. There is a risk criteria donor. Now, these are donors whose social or behavioral history could put them at a higher risk for transmission of infectious diseases such as HIV, hepatitis, syphilis, any of those kinds of infectious diseases. But here's the deal. We are monitoring the ICU records of that donor. We're looking at all the lab results for those things such as HIV and hepatitis. And we're looking at them and they are showing negative, negative, negative. Whether that donor is in this category for a risk criteria or not, there is always a less than 1% chance that they have contracted some disease that just hasn't shown up on the lab work yet. There's a reason why we'd like you to consider that risk criteria donor. And that's because often they're younger donors and those kidneys are really good kidneys. We are monitoring that risk. We are monitoring those lab results for you, and we always recommend that you would take it. Now, if you get a donor offer from one of these categories or people in this category, we will notify you, and you do have the right to refuse this offer if you choose to. When measuring the quality of the donor kidney, it's called Kidney Donor Profile Index, or KDPI. And numbers go from 1 to 100. 1 is the highest quality, 100 is the lowest quality. The more things somebody has wrong with them, the higher the number. There's a lot of different factors in considering that calculation. All regular offers go up to an 85% KDPI, but if you want to capture those extra offers from an 86 to 100, you will need to sign an additional consent form. And studies have shown that those kidneys might start a little later, but they could last just as long. And this is a conversation for you and the nephrologist. Some of the benefits of accepting one of those KDPI 85% or greater kidneys: you could get transplanted faster, you'll get more offers, you might enjoy that benefit of the functioning kidney and have a better quality of life, and no more dialysis. Some of the risks: delayed graft function. And what that means is sometimes it just takes a while for that kidney to kick in and start working. Now, there's also a scoring of all of the recipients, and that is called estimated post-transplant survival, EPTS scoring. Kind of gives you an idea of how long you're going to need the kidney. So whereas a KDPI might analyze how long do we think that the kidney's going to last, the EPTS score is going to analyze, well, how long, based on your health history, do we think that you're going to need a kidney? So factors are going to include your age, how long you've been on dialysis, whether you've had a prior transplant, all of your health history. And again, that scoring goes from 0 to 100%. And patient with a lower EPTS score, whether it's 20% or less, they're expected to have more years of function from a donor kidney compared to people who have a higher EPTS score. There are a lot of different factors when allocating organs. Allocation means matching donors and recipients. Wait time, that's a big deal. The longer the wait time is, the more opportunity you're going to have to start getting donor offers. Blood type has to be compatible. Whether you've been a prior living donor or not is going to maybe bump you up on the list if you've been a prior living donor. Geographic distance is a factor. Organ size is a factor. We cannot put a kidney from a 350-pound guy into a 90-pound woman. And of course, the scoring, EPTS score and the KDPI score. And one other thing that I have not spoken about yet is the PRA, which is your antibody level. The higher antibody levels you have in your system, the more likely you are to reject a kidney. So these are all the different factors that the computer puts into place when matching donors and recipients. You might ask what happens when you're called for a kidney offer. So we would notify you that you have a possible organ offer out there, and we're going to ask you questions about your current health status. We've got to make sure that you're infection-free, that you're not sick, that you don't have any wound infections, that you still have your insurance in place, And we would also be notifying you of things like whether that donor kidney came from a risk criteria donor or not. And we're going to be able to possibly give you a general time frame before the surgery is going to happen. So we would have to ask you all of those questions because we would not be able to transplant you if you were sick. Sometimes we have to bring patients into the hospital, and for whatever reason, the surgery is not going to work out. You do have a little bit of a risk of being sent home due to these unforeseen circumstances. And with that, I'm going to hand you off to one of our post coordinators.
Hi, my name's Jessica. I'm one of the post coordinators here at the Transplant Institute. My job starts when you come to the hospital for surgery. We're going to go through what to expect once you arrive. Surgical phase. A few things to know about surgery is surgery lasts approximately 3 to 4 hours. After surgery, you're moved to the recovery room where you'll spend an additional 1 to 2 hours there. While you're in surgery, we'll place a Foley, a central line, and a stent. Kidney transplant recipients can expect a lower abdominal incision, and pancreas transplant recipients will receive a midline incision. A pancreas recipient will also expect a drain and an NG tube to be placed during surgery, and will go to the ICU for monitoring afterwards. On your screen, you'll see an example of a central line. A central line is really just a long IV catheter. It runs directly to your heart. It allows us to give you those medications that are super important for transplant, and it allows us to do blood draws. The other image on the screen is a Foley catheter. It collects your urine in a bag and allows us to accurately measure it because we want to know how much urine your new kidney is making. This is an example of a stent. As you can see, the stent runs from the kidney into your bladder. We will schedule your stent to be removed 6 weeks after surgery. You will go to a urologist's office to have this procedure done. We'll set up your appointment before you discharge. Here you'll see where to expect an incision for the kidney transplant and a diagram of how we hook up the kidney. The ureter is attached to your bladder and the graft is attached to your vessels in your lower abdomen. As you can see, your native kidneys stay where they are. Possible complications after transplant. In the first 6 months, the risk of rejection is quite high, which is why it's very important that we work as a team to review labs and monitor medications. Other possible complications include blood clots, bleeding, wound infection, delayed graft function, depression, or other viral and bacterial infections. So during the inpatient phase, you are on the transplant unit where you have a 1-to-1 nurse-to-patient ratio for the first 24 hours. That means you are your nurse's only patient. They will be monitoring you frequently, checking vital signs, and measuring accurate urine output. They will draw labs from your central line every day. You can also anticipate daily education for you and your caregiver regarding diet, medications, and transplant care. Kidney recipients need 6 hours of bed rest after transplant, and pancreas recipients need 24. After your bed rest is up, we will want you up and moving. Just like at home, we want you sitting up in a chair with meals and getting up and walking at least 4 times a day. We will want you to wear your mask to stay safe in the hospital. While you're in bed, we'll want you to wear SCDs on your legs. This improves blood flow for circulation, preventing those blood clots. SCDs are an intermittent compression device system. We will also give you an incentive spirometer and show you how to use it. It ensures that you're taking good deep breaths to prevent pneumonia. Outpatient expectations. After transplant, we will need labs every Monday and Thursday for the first 3 months. It's very important that we check your levels and monitor how much medication you're getting for your kidney. You can expect to follow up with transplant about every 2 to 3 weeks. Communication is very important. Any questions or concerns you should take immediately to your coordinator. When we call you for medication changes or to check up, you should call us back if you missed that call. You don't want to miss any important information. You won't be allowed to drive for 3 weeks after surgery, longer if you're still taking pain medication. Compliance with medications, labs, and follow-up care are mandatory for the life of the transplant. Your caregiver should be available for you for at least 3 months. Again, please don't change your insurance even after transplant without talking to our office first. And last but not least, water. We know you're not used to drinking water, but your kidney needs water to stay happy. A few other things to remember. Transferring your transplant care is allowed after surgery, but our center is responsible for your outcomes for a minimum of 3 years. After those 3 years, if you want to transfer your care, we are here to support you through that process. If you move out of state, we understand, and we definitely want you to get a transplant provider closer to you. But again, that goes back to communicate with us, and we'll work with you. Thank you so much for your time. Now, here's Susan to finish things up.
So while you're waiting for that kidney, we want you to take care of your health. You need to keep your appointments with us. Participate in a mentor program. We want you to follow your diet and your exercise guidelines and come in for your annual evaluation and testing updates. We want you to stay involved and notify us if anything changes in your health status. Stay close to your family and friends. Be available to us 24/7 and return our calls. Please notify us. These are really important things to remember. We want you to notify us before you change your insurance so that we can talk you through the right insurance plan for you. Notify us if you change your phone number. If I have a kidney offer for you and you've changed your phone number, I'm not going to be able to reach you. If you change your dialysis centers, we need to know about that. If you are just starting dialysis, we need to know about that. If you get hospitalized, we need to know those things. And if you change your caregiver, we need to know about that. These are things that are very, very important for you to notify us about. And for those of you who are considering a kidney and pancreas transplant, there's just a few more slides that we need to go through. A pancreas transplant is the surgical transfer of a pancreas from a deceased donor. And in order to be qualified for a pancreas transplant, you have to be a type 1 diabetic or have diabetic nephropathy and dialysis dependent or dialysis imminent. You've got to be able to withstand the surgery, and you need to be less than 55 years old. Here's a picture of the pancreas transplant, and you will have a midline incision in that. If you get a kidney and a pancreas transplant, you can see the slide here of where the placement of the organs are. And facts about pancreas transplant. You should no longer need insulin. You can eat a more regular diet. You will have few or no reactions from low blood sugar or insulin. You can be more active, more independent, and the high blood sugar will not damage your kidney. Endocrinologist might be a part of your care with a pancreas transplant. And with that, I want to thank you for choosing the Transplant Institute at Research Medical Center.
Thank you for choosing the Transplant Institute at Research Medical Center.